patient and the patient insisted upon it, would you walk away?
I would never administer what I consider to be inappropriate medical care to any patient.
Okay, so is that answer yes, you would walk away if they insisted upon it?
Yes.
Thank you. Now, why is there a need for the continuous observation of individuals when they're sedated or anesthetized by propofol?
Well, I think a major reason is if you're providing sedation, it's very easy, as we've discussed, to go from one level of sedation to another, either deeper sedation, closer to anesthesia, or lighter sedation. You can also have a situation where the effects are wearing off, and you may have a patient who's wide awake because propofol has a very short duration of effect when you turn it off.
And for that reason, this what you refer to as a continuum of sedation, that's one of the reasons why you need to have constant monitoring of the patient, correct?
When you're administering an infusion or repeated bolus injections, yes, that's correct.
Was it your testimony that if you inject someone, let's say with just 25 milligrams of propofol, is it okay to then just walk out of the room and leave that person alone without any monitoring equipment?
My testimony is that giving a 25 milligram dose of propofol will have minimal effects, lasting less than 15 minutes. So if a patient is observed for 20 or 30 minutes after a single dose, I see no reason why one cannot leave their bedside. As I mentioned, there are studies giving small doses for pre-medication before patients leave a...
Well, and those studies, to be fair and accurate, you don't look at just the dose, you look at the effect on the patient, correct? Because the effect varies from patient to patient, correct?
Absolutely correct.
Okay. So when you keep saying the dose, you have to also look at the effect. Would you agree?
Yes, and that's why I stated, sir, that you monitor the patient for at least 15 minutes after even a small dose, because this patient, a given patient, may have an exaggerated response.
And then after 15 minutes, it's okay to walk out of the room and leave them on their own. Is that your testimony?
I'm saying that if I give a small dose of propofol, that is a minimal sedating dose, 0.4 milligrams per kilogram, and I observed the patient and saw no untoward effect for 15 to 30 minutes is what I said. I said a minimum of 15 minutes, but ideally observe the patient for a half hour. I would see no problem in leaving the patient's bedside.
And that would be in a clinical setting? Medical hospital, office suite, something of that nature, correct?
That's the only setting in which I've given the drug, so
Correct.
Yes.
But even in that setting, it's your testimony that you would inject a patient, and I want you to assume they're not hooked up to any monitoring equipment whatsoever. There's no personnel in the room. You would inject them with 25 milligrams of propofol, watch them for 30 minutes, and as they continued to sleep, you would leave them alone without any monitoring equipment or people on hand? Is that what you would do?
In the hospital setting, as we discussed earlier, typically they have an EKG running. They typically have a pulse oximeter on a finger. So I wouldn't characterize it as no monitoring. Having a pulse oximeter in place represents monitoring equipment. So,
Well, if you're in the room, if you're out of the room and it doesn't have an alarm, it really doesn't represent anything, does it?
well, it depends where you can observe. But I think that...
Well, if you can't see it and you're out of the room, a pulse oximeter without an alarm means absolutely nothing. Wouldn't you agree?
I don't agree that it means nothing.
What value does it have if you're out of the room, you can't see it, and it has no audible alarm, and no one else is there? What value does a pulse oximeter have with no alarm?
Well, if you've observed the patient for a period of time and the pulse oximetry value, the saturation is stable, we know that propofol in a 25 milligram dose will have effects that last maybe 5 minutes, maybe 7.5 minutes, and beyond that, virtually no effect. So if you've observed them for 25 or 30 minutes, I think you can certainly move away from the bedside.
Okay, that wasn't my question. My question is, I'm asking about a pulse oximeter without an alarm. If you are not there to see it, to see the little tiny screen, and you're not there to hear it, it doesn't even have an alarm, what value does it serve?
Well, only
In your absence, what value does it serve in your absence?
in your absence, it probably has little, if any, value.
None,
Correct.
correct?
Well, yeah, that's true.
Okay, it has no value, correct? If you're not in the room. Correct?
Correct, yeah.
Thank you. And 25 milligrams of propofol, which you keep referencing, of course, assumes no other benzodiazepines are on board, right?
It certainly no acutely administered benzodiazepines. If they've been administered hours before, they would probably have very little, if any, effect.
But they could have an effect.
They could have an effect dependent on the time interval between the administration of the last dose of the benzodiazepine and the small dose of propofol.
Well, would that influence if you knew that a patient had, I'm talking about you personally, if you knew a patient had lorazepam and midazolam on board and you gave 25 milligrams of propofol, would you still just walk out of the room after observing them for 15 to 30 minutes? Or would that be something that would raise your awareness to maybe pay a bit more attention?
I still feel that that is adequate, in particular if the 25 milligrams of propofol is administered over 3 to 5 minutes, very, very slowly. That represents a very slow dose that would not be expected to achieve a very high peak level.
So you, again, my question was, would you, knowing that benzodiazepines were on board, and you administered 25 milligrams and the person had not woken in your 15 to 30 minutes of observation, would you be comfortable then leaving them alone without any monitoring equipment? Yes or no?
I said it depends on the time interval between the last dose of midazolam and the slow bolus injection of propofol.
So would the fact that you knew benzodiazepines were on board in any amount alter your level of care?
I would certainly observe the patient carefully, as I would even if it was just propofol alone.
But just for 30 minutes?
I think 30 minutes is certainly adequate for a slow 25 milligram bolus dose of propofol, even in a patient who has hours earlier received a small dose of midazolam or lorazepam, yes.
And that would be the acceptable standard of care, to administer midazolam and lorazepam and 25 milligrams of propofol, and with the patient not being hooked up to any monitoring whatsoever and no staff on board, it would be appropriate for you to walk out after 30 minutes. Is that your testimony?
Are you asking me about the standard of care or the standard practice?
I'm asking about the standard of care. Would you, and I'm asking about you personally.
Well, the standard of care is the ultimate or most ideal standard of care, and obviously the standard of care would require monitoring, as I've suggested earlier.
Okay, so is that then that you would not leave that patient alone without any monitoring or any staff to make sure that they're safe? You would not do that? Is that correct?
I would observe the patient for a period of time. If this was an unusual case because the doctor was trying to achieve allow the patient to achieve a sleep state. So I think that once the patient was resting apparently comfortably and had been observed for a period of time such that the risk of either respiratory or cardiovascular adverse effects had passed, it's not unreasonable to leave. It certainly is done in practice if you're giving a small dose on a one-time basis. It's quite different than a situation where you're giving an infusion or repeated doses. Then it would absolutely be unacceptable.
What if in your mind you had previously made statements that the patient likes to push the propofol themselves. Would that change your willingness to just simply walk out of the room and leave them alone with no monitoring?
It would certainly make me careful about allowing access to drugs.
Would you walk out of the room and leave them alone with no personnel and no monitoring if you're of the opinion they like to push propofol themselves? Would you walk out of the room in that situation, yes or no?
No, I would not leave the room.
Thank you. You can't justify Conrad Murray's failure to call 911 in the period of time, or in the waiting essentially 20 minutes to call 911, can you?
No, I cannot.
That's an extreme deviation from the standard of care, wouldn't you agree?
Again, these classifications are not familiar with me. I would say that given the fact that Dr. Murray is a cardiologist who is certified in advanced cardiopulmonary life support.
Objection assumes facts, not in evidence.
Overruled. You may finish your answer.
Did he act like someone who was well-skilled in advanced cardiac life support? Did he act like that?
I was not present to make that assessment, sir.
You've taken all his statements as true in your assessment, correct?
I wouldn't necessarily say I've taken all his statements as true, no.
Do you think, from your review of his statement to the police, that he acted like someone who was well-skilled in advanced cardiac life support?
I think Dr. Murray, upon returning to Michael Jackson's bedside and finding him apparently in full cardiopulmonary arrest, probably reacted as many physicians would. He was very probably anxious, and in those situations, it's very stressful for anyone, even someone who is ACLS certified.
So is that no? He did not act as a well-skilled person trained in advanced cardiac life support?
I didn't say that, sir.
Okay, well, I asked the question, and I'll ask it again. Did Conrad Murray, in your opinion, based on his statements to the police, act like someone well-skilled and well-trained in advanced cardiac life support?
I can't make that assessment. I would have done things differently in terms of calling for help and in terms of calling 911.
What would you have done?
Immediately, I would have called for help, although I understand this was sort of an isolated area, and there was, it was...
Isolated area?
Of the house, yes, I understand. It was a special suite of rooms on...
It was a bedroom upstairs.
Yeah, but
okay.
Removed...
What would you have done? That was my question. What would you have done? You said you would have called for help.
I'd have called for help. I would have assessed the patient, initiated cardiopulmonary resuscitation immediately.
And after making an assessment and starting cardiopulmonary resuscitation, if you were in that situation and you knew you had no personnel on hand and none of the resuscitation equipment, wouldn't you call 911?
Yes, I would call 911.
Okay.
But my understanding, if I may, is that this was an unusual situation because this was a house that had a secure perimeter and had no phone lines in the house. So it's not a typical situation where you can call 911 and have immediate access to the premises.
I would certainly agree this was an unusual situation, but Conrad Murray had a cell phone in his hand by his own statement and used it to call Michael Amir Williams. Are you saying he was not capable of pushing 911, maybe putting the phone down on speakerphone and continuing with the cardiopulmonary resuscitation?
It's my understanding that, number one...
I'm asking your opinion.
Okay, my opinion...
About what you would do. There was a cell phone. Conrad Murray used it to call Michael Amir Williams. If you were in that situation, you come on the patient, and he's in full cardiopulmonary arrest,